coronavirus is the enemy, of the world. So recently, the Chinese Society of the Laboratory Medicine have organized, more than 10 experience exchange academic activities about how to against the coronavirus, together with some other societies, some of them in India, Indonesia, Russian language countries, or some others. For today, I think it's also a very important academic activities. Two famous professors have been invited to be as speakers. One is Mauro Plebani from Italy. Another is I will to introduce more about, another is Qi Yang from a very famous hospital in China, Peking University Hospital. It's a very famous hospital in China. For the first, I think I will to first speakers, Professor Mauro Plebani. He is a full professor at the School of the Medicine in the University of Padua, and the chief of the Department of Laboratory Medicine at the University Hospital. He was appointed the Dean of the Medical School of the University in 2017. He also, as the honorary professor at some university in the world. Also, he has many titles. Just because the time is limited, so I don't want to introduce more. Let's welcome Professor Mauro Plebani. Welcome.
Good morning, dear colleagues and friends. First of all, I like Mindray for making possible this webinar. And the title of my presentation is about the central role of clinical laboratory in diagnosis and management of COVID-19 disease. So I'm from Padua University, the medical school of Padua University, and I hope you can appreciate the first anatomic theater in the world, as you can see in the left side of the slide, and the magnificent Aula Magna dedicated to Galileo Galilei, Galileo Galilei, who did teach in our university at least for 10 years, many years ago. So, laboratory testing in SARS-CoV-2 or beta COVID-19 goes far beyond virus detection. In fact, as we presented in this review that was wrote with my friends, Professor Lippi, the critical role of laboratory medicine in this disease is about at least 3 major areas. And in these areas, laboratory diagnostic provides essential contribution, supporting diagnostic and clinical reasoning and the management of the patient. And this includes the etiological diagnosis, patient monitoring, and last but not least, epidemiologic surveillance. So this slide well shown the previous concept. As you may understand, the clinical laboratory play an essential role in diagnosing the infection, and we will deal with the molecular testing and eventually with the use of serological tests. In other disease, the staging, prognostication, and therapeutic monitoring of the patient are based, at least in part, to laboratory information. And finally, when the disease recovered, the patient recovered, the use of serological tests for epidemiologic surveillance is absolutely important. So, in this slide, you can see how important is the identification of high-risk patients, because there are some comorbidities which makes more severe the disease in patients with diabetes, chronic disease, chronic kidney disease, hypertension, other infectious disease. And patient triage is very important using molecular tests and serological antibodies detection, as well as for the diagnosis, as well as for recovery, and finally for patient monitoring. So there is a wide range of intervention of the clinical labs in this disease. What I like to say is that we have to deal with the right test at the right time for the right patient. So molecular testing is the most important, we may say, the gold standard for the diagnosis of this disease. But even serological tests are very important to identify convalescent patients for the study of the immunomodulation mechanism and for epidemiological surveillance. Finally, many laboratory tests are essential to better understand the disease severity and for prognostication. Prognosis is another very key issue in this disease. So, first of all, the diagnosis. Why is it so important, the molecular test in diagnosis? Because now we know that even asymptomatic subjects may spread the disease, and even this in so-called pouchy symptomatic subjects with mild to moderate sign of the disease. So in this type, the clinical story is poor, and the detection of the disease is possible only using the laboratory tests, in particular molecular tests. And this is one of the first cause in which it was demonstrated in one, the exposure to a symptomatic carrier of the COVID-19, which led to the spread of the disease in a familial cluster. As you can understand, this patient traveled from Wuhan to Anyang and was completely without any symptom. But unfortunately, he was contagious, and at least 6 members of the families developed the disease. And in the bottom part of the slide, you can just appreciate a little bit the behavior of some laboratory test results, CRP, increase of the decrease of lymphocyte, and a little bit increase of neutrophils. So, for sure, up to now, we have to recognize that the gold standard for the diagnosis is a molecular test that is RT-PCR. And this is very important, the recognition of the importance of the gold standard, the reverse transcription polymerase chain reaction on respiratory tract specimen. But as for any other laboratory test, the diagnostic accuracy of this technique can be considered a foremost prerequisite as for all other laboratory tests, and as for all other laboratory tests, there are some analytical and pre-analytical vulnerabilities. So we have to strongly be careful in managing the pre and analytic phase of RT-PCR for SARS-CoV-2. And in fact, in this paper we have published recently, you can see there are some vulnerabilities in pre-analytical phase. For instance, lack of right identification of the sample, a poor procedure for specimen collection, handling, transport, and storage eventually, and some other specific pre-analytical problems are possible sample contamination and testing in patients receiving antiretroviral therapy. The other vulnerabilities came from the analytical phase. Testing carried out outside the diagnostic window, active viral recombination, use of non-adequately validated assays, lack of harmonization of primers and probes, instrument malfunctioning, and this should have led to some problems and errors in the test. So the practical indication to minimize the risk of diagnostic errors in a COVID-19 infection is to combine the results of the molecular test with clinical and epidemiological evidence, with the chest computed tomography, particularly when ground glass opacities are present at the CT, to eventually recollect and test upper respiratory specimen in patients with negative RT-PCR, but high suspicion and probability of an infection, provide clear instruction on how nasopharyngeal and oropharyngeal swabs shall be correctly collected, managed, and stored. So it's very important to develop and spread standard operating procedures, making easier and better the measurement, the molecular tests. Particularly this is the recollection and test respiratory specimen in patients with negative RT-PCR, but high suspicion is very, very important. So sometimes a negative result should not exclude the disease. This is a figure explaining the position of amplicons target of the coronavirus. And as you can appreciate, there are several domains. And therefore, in this slide, you can appreciate the oligonucleotide, the sequence, and what we have made to recognize the RDRP gene, the E gene, and the N gene that are the most specific source for recognition of the virus, of the new COVID-19 virus-related disease. And the other issue is the time window. As you can say, starting from the infection and before the symptom onset, there is a phase in which it should be false negative, the molecular test, because we can recognize that before the symptom onset, there are some days which should lead before it's possible to recognize the virus in the swab. And the same after the symptom relief, there are some days in which still there is a diagnostic window for the molecular test, but there is a room for false negative result after this window. So it's very important to recognize the limitation of the molecular test regarding the time starting from the onset of the symptom and the symptom relief. And this is another paper from publishing Lancet Infectious Disease from the group of Kai Wong, in which you can see the behavior in terms of viral load of the molecular test in samples from saliva in comparison to endotracheal aspirate. And as you can see, the viral load is decreasing from the time zero or beta, from the time in which the virus is present, and the time after symptom onset after 20-25 days is no more present and detectable in both saliva and endotracheal aspirate. And this is another picture slide from the same paper in which you can appreciate the difference in viral load between severe disease and mild disease, and the viral load, once again, in patients with no comorbidities, which is a little bit lower than patients with one or more comorbidities. What about serological assay? We know that the median seroconversion time from antibodies, both IgM and IgG, were more or less from day 11 to 14. In some papers, the presence of antibodies was lower than 40% among patients at the beginning of the onset, the first week since onset, but rapidly increased at more or less near to 100% since 15 days after onset. So even for serological test, or better, more for serological test, the time window is very important. And in this paper, the combination of molecular tests and antibody detection significantly improved the sensitivity of pathogenic diagnosis, even in an early phase. But before moving to serological assay, some steps should be performed. First, analytical validation, as for any other laboratory test. That means imprecision, repeatability, dilution, recovery studies. Seroconversion time and rate, so the knowledge of the kinetics of the antibody. And we have to know the diagnostic specificity and sensitivity of the assay, and better, the predictive and negative, the predictive positive and negative value of the assay. And finally, how we can use serological assay for epidemiological studies. So, as you can see in this slide, there are several methods to recognize the spike protein. In this case, the recombinant NP and RBD spike protein have been used to develop an immunoassay. And there is a lot of debate in the literature which specificity may assure the best specificity to an assay while maintaining the sensitivity of the assay itself. And this is from a recently published paper in which we demonstrate the increase of IgG in comparison to the IgM. And I can say that we used recently a prototype assay from Mindray, which demonstrates better kinetics for IgG. In this paper, we have demonstrated that after 12 to 13 days, there is at least 80% of increase for IgM antibody, while at the same days, 12 to 13, 100% of IgG were detectable present in the sera of this patient. And this is a very important information to address the measurement of the antibody. This is from another paper published on the same. You can appreciate the behavior of IgG and IgM, and a little bit the behavior in severe cases on the left in comparison to mild cases on the right side for both antibodies. So there is a little bit different even in the kinetics between severe disease patient and mild disease patient. And this is another very interesting take-home message. What about rapid test? There are some papers, particularly this paper that is already published now, that reveal a very low sensitivity, less than 20%, for one of the rapid tests developed and commercialized. And this creates some problems. In particular, may lead to misdiagnosis of COVID-19 disease in the majority of patients. But I can say that a more recently published paper demonstrates that other rapid tests perform much better than this one. And therefore, validation of rapid tests is absolutely important, is a prerequisite before any study in which the rapid test should be used for both diagnosis and monitoring of COVID-19 patients. And in particular, serosurveillance is going to play a major role in a framework for getting back to normal. And we have to better understand the value as well as the limitation of serological tests and use them for the right reason, in the right patient, at the right time. What about prognosis? There are many papers already published dealing with the value of laboratory tests in prognostication of the disease and in the prognostication of the severity of COVID-19 disease. In particular, as you can see in this paper it was highlight the value of the increase of D-dimer greater than 1 microgram per liter to identify patients with poor prognosis at an early stage. So in this case, the increase of D-dimer allow very interesting information for an early prognostication. But there are many other laboratory tests that should be used to define the severity of COVID-19 disease. In particular, lymphopenia, that means a decreased immunological response to the virus, leukocytosis and neutrophilia that highlight bacterial superinfection, thrombocytopenia that highlight the consumption of and a coagulopathy that is very common in this patient, as well as the increased value of CRP, procalcitonin, LDH, to highlight the infection and the superinfection, increased the value of aminotransferase bilirubin to highlight the presence of liver injury, and increase the value of creatinine to highlight the presence of kidney injury. The increase of cardiac troponin is well defined a cardiac injury, and so on. So other laboratory tests, particularly D-dimer, as previously explained. And in this paper from Zhu, once again, you can see how well discriminate survival from non-survival. Some laboratory tests, particularly platelet count, that are much lower in non-survival. Aminotransferase, ALT, creatinine, lactate dehydrogenase, troponin, D-dimer, once again, serum ferritin. You can appreciate the increase of values, particularly in non-survivor patients. Interleukin-6, that is much increased in non-survivor. And this is better shown in this slide, in which you can appreciate the monitoring of this laboratory test over time. Starting from the upper side on the left, D-dimer, you can appreciate the continuous and dramatic increase in D-dimer values in non-survivor patients. You can see lower the increase of interleukin-6, and in the bottom of high sensitivity cardiac troponin. On the right side, you can appreciate the difference once again between survival in red and non-survival in lymphocyte count, serum ferritin, and lactate dehydrogenase, LDH. This is a meta-analysis we have published on procalcitonin, and you can appreciate the added value as a prognostication of the increase in of procalcitonin values. That means that highlights a superinfection with bacterial superinfection in this patient. And this is another marker of infection, is a perception. This is quite new. This is a paper we have recently, very recently published, in which, as you can understand, patients with values higher than 250 or of presepsin present a poor prognosis, longer hospital stay in comparison to patients with lower than 250 nanogram per liter of presepsin. So this is a quite new insight. Take care. This is another meta-analysis we have published in which you can appreciate the decrease of platelets, thrombocytopenia, is strongly associated with severe disease. And this is very clearly depicted in the slide. Prominent change in blood coagulation are, first of all, the increase of the dimer, already explained, increase in fibrinogen degradation product, and in other coagulation tests. But more interesting is the data provided me by and collected in this slide, in which you can see with the Mindray hematological analyzer, it was possible to well highlight how many hematological parameters may differentiate survival from non-survival patient. That means severe versus non-severe COVID-19 diagnosis. And you can see the number of lymphocytes particularly is progressively decreasing. The number of neutrophils is progressively increasing in non-survival. The RGV is very important, but also the reticulocyte number and red blood cell distribution width is very interesting, as well as platelet count and very interesting immature platelet fraction. That is a quite new parameter. As you can see, is the admission is slightly increased, but progressively is increasing after the, and finally CRP slightly increased. So hematological tests provide useful information about the severity of the disease and may and should use in patient monitoring over time. I like to summarize the most frequent laboratory abnormalities in patients with COVID-19 disease. A decrease in blood lymphocyte count, albumin and hemoglobin, an increase in neutrophil count, in erythrocyte sedimentation rate, an increase in C-reactive protein, as well as in lactate dehydrogenase and alanine aminotransferase, as well as aspartate aminotransferase. And other increased laboratory tests are for cardiotroponin, procalcitonin, prothrombin time, sometimes, D-dimer, very important, and as I show you, presepsin is another very interesting parameter. And in this slide, I like to summarize the essential laboratory testing. So every day in this patient should be performed the CBC count with differential count, a comprehensive metabolic panel including electrolytes, total protein and albumin content, creatinine, bilirubin, one of transaminase, particularly ALT, eventually CPK, total creatinine kinase, but more important, lactate, and lactate is very interesting parameter. For risk stratification, D-dimer is very important, as well as ferritin, CRP, ESR, LDH, and cardiac troponin. And another important differential analysis should be performed to understand if other viral are present in the patient, HB virus, as well as HIV, of course, disease. So, as you can appreciate, there are many tests that should be performed every day or at least every week to better monitor the disease course in COVID-19 patients. And finally, I like to emphasize one point, that is that laboratory tests should not be performed only in central laboratory setting. There are papers dealing with the installation of the so-called mobile labs using point of care or easy to perform instrumentation, establish new laboratory and emergency platform, and we know the incredible support made by Mindray in creating new laboratory platform in Wuhan and in other Chinese hospital settings. And another interesting point is to reinforce the network of regional labs, because a laboratory clinical labs should cooperate and collaborate, making possible the exchange of information, knowledge for better care of the patient and better knowledge of the disease. That is quite important issue at this time, because we have to learn more about the virus, SARS-CoV-2, about the disease, COVID-19, about the tools, laboratory tools we have and we have to develop to fight against the virus and against COVID-19 disease. So we have to fight against the virus, and we win the fight if we cooperate at an international and national level. And I like, once again, Mindray for giving me the opportunity to share my knowledge and ideas with other colleagues around the world in this webinar. Thank you so much.
Okay, thank you, Professor Panabani. You know, Professor Panabani's speech was very wonderful, I think. You know, I want to leave a little time for the question and answer session later. So I'm not going to spend the time to give a comment or a summary. Thanks again, Mario Panabani. So next is Professor Chi-Wen Yang. You know, Professor Yang is a full professor of the Peking Union Medical College and deputy director of the Department of Laboratory Medicine of the College Hospital, Secretary General and steering committee member of Chinese Committee of the Antimicrobial susceptibility testing. Also, it's a European Committee of the Antimicrobial susceptibility testing. Professor Yang, is famous professor in China. Also, is an excellent young microbiologist. So, welcome, Professor Yang.
Hello, everyone. I'm Professor Qiwen Yang from Peking Uni Medical College Hospital. I'm honored to be here to take a presentation on the virus antibody detection in the management of COVID-19 and tell you something about the experience in China. As you know, there are 7 coronaviruses which can cause human infections, and 4 of them are low pathogenetic HCOVs. They are HCOV229E, HCOV-OC43, HCOV-NL63, and HCOV-HKU. And other 3 are highly pathogenic COVs. They are SARS-CoV, MERS-CoV, and also in this spring of 2020, we faced the new severe acute respiratory syndrome CoV-2, which is also called SARS-CoV-2. So let's look at the pandemic of COVID-19. And to the date of April the 27th, 2020, the total confirmed cases is nearly 3 million in the world. And we can see many countries have have many cases, and even in some countries, the number of the confirmed cases also increasing. So this is not a good news, but we also have the confidence to control it. So what is SARS-CoV-2? And at first we just know it a virus. It is a virus, but what is the structure of this virus? So let's look at this picture, and this is a picture from a manuscript which is published in Cell. And we can see the SARS-CoV-2 viruses is a round-shaped virus, and it has an envelope and also have some spores on the surface of the bore. And we can find on the surface of the bore they have spike glycoproteins, and that is responsible for receptor bonding and membrane fusion. And this spike glycoprotein is also the key protein which can be used to recognize this virus. And in the membrane, we can also find the envelope protein, which is important for virus infectivity, and also the matrix glycoprotein, which is the most abundant structural protein and will also interact with protein E to form viral envelope. And inside the virus, we can see 2 structures. That is the N protein, that is helical nucleocapsid protein. And around the N protein, we can find the single-strand RNA, which is very important for the maintenance of the structure of this virus. So this is the structure of this virus. You can see this is a very simple structure, and also the genomic. It's just 30 kilobases. So it is small pathogens which has small genome, but it can also lead to very severe illnesses. So we can have a look at this picture, and we can see the importance of the laboratory detection of COVID-19. So if you face a patient which is expected to the COVID-19, you may ask for the laboratory clinicians whether we can diagnose it as fast as possible. Actually, to my point of view, there are 2 main methods which can detect the COVID-19. One method is from RNA, and RNA detection is focusing on the virus. And the other method is from antibody, and the antibody came from patients. So once the patients were infected by the virus, our body will create some antibodies to combat the infection of this virus. So the antibody types also have many types. Actually, we have IgG antibody, IgE, IgD, IgM, and IgA antibodies. So different antibodies will increase in different stage of the infections, and we can see the different content of the antibodies in our bodies in different stages. So the focus of my topic is antibody detection. So I will discuss this topic from 4 points. The first point is antibody dynamic change during the course of disease, and this will be very helpful to for us to understand the dynamic change of the antibody and know when the antibody will appear and when the antibody will change. And the second is antibody detection methods. Only we know what method can be used in the antibody detection, we may know the false positive or false negative of these methods, and only that we can use these methods to the to the most important. And the third, the clinical interpretation of antibody detection. So the clinical interpretation is also very important because the laboratory examination is simple, but clinicians should understand the result, especially the antibody result, because it is sometimes difficult to interpret. And finally, I will tell something about the false positive and false negative of the antibody detections, because this is sometimes confusing, especially for the clinicians and sometimes for the laboratory staffs. So firstly, let's look at the antibody dynamic change during the course of the disease. Actually, most of the time we will discuss IgM and IgG, these two antibodies, in the course of the disease, because these two type of antibodies is very important for recognizing the stage of the infection. And we can find IgM will increase very rapidly after the infection, but the content is low. It will appear in the early stage, but the duration time is very short, always 2 or 3 weeks after the infection. And the IgM antibody is also an indication of the acute phase. But IgG is different. IgG will appear after the IgM come to a high point of the high peak of the concentration. But the IgG will have the relatively higher content than IgM. The stage indicates the later stage than IgM, but the duration time is long, and sometimes the IgG concentration will remain in the body for several months or even several years. It always indicates the middle to late stage of the infection or previous infections, because IgG is a protective antibody, and it will maintain and assure our bodies to the viruses. So this is an interesting picture, and this picture will help you to understand how the antibodies, especially IgG and IgM antibodies, change during the course of the infections. So firstly, we can find in after the infection, maybe after 3 to 5 days after onset, the SARS-CoV-2 specific IgM antibody will become detectable. Nearly 7 to 9 days, the IgM antibody will reach a higher peak. But after that, the IgM antibody will decrease very rapidly, and the IgG antibody will increase. So IgG can be detected around 10 to 15 days after onset. And SARS-CoV-2 IgG will always reach its titration of at least 4-fold increase during convalescence compared with the acute phase. So that is will be also a very important principle that we diagnose the COVID-19 by using the IgG titration. Because if we found the 4-fold increase during the convalescence compared with the acute phase, we can diagnose the disease by the IgG titration. So this is a very important principle. And also, we can also find the clinical value of SARS-CoV-2 IgM and IgG, and this is the data which is from the dynamic company, and they have done such a study of the combination of IgM and IgG performance to diagnose the COVID-19. And the figure A is the IgM and figure B is the IgG. And we can find from the figure A, the level of IgM showed an upward trend in the early stage, and with the highest level in the middle stage. And after the middle stage, then the level of IgM antibody will show a downward trend in the late stage. So this is very consistent with with the stage of the infections. So which also indicates IgM is the first antibody after the infections. And the figure B is the IgG antibody, and we can also find this IgG antibody. The level of IgG showed a gradual increase in the early, middle, and the late stage of the course of COVID-19, and the level of IgG in the late stage showed more than 4 times higher than early stage. So this is the very important principle to diagnose this disease. So this is a dynamic change of the antibodies, especially for the IgG and IgM. And only when we understand this change, this is a dynamic change, we will understand which method we will use and how to interpret the result from these methods. So let's go into the second part, antibody detection methods. So if you are staff in the department of a laboratory, you will find many clinical laboratory methods to diagnose diseases, especially for the infectious diseases. So, the firstly, we'll look at the colloidal immunochromtographic assay. So this is a very long term, but we can abbreviate it as GICA. So in this method, we use very special materials, which is called colloidal gold, to indicate the presence of the antibodies, because we will locate the the antigen on the membrane of the test strip, and let the sample, especially maybe the serum or the plasma, to go through the plate. And after that, the antibodies in the serum or plasma will combine to the antigens on the membrane. And after that, we will use a colloidal gold labeled antibody to detect whether there is an antigen and antibody complex. So this is actually this is a immunoassay, but we use a special substrate to show the reaction of the immunoassay. So the test is simple. From the left side of this figure, we can see that we just need to put the samples on the spot and let the serum move to the strip and go to the other end, and after 10 minutes, we can see the lines which indicate the IgG or IgM positive or negative. And in this strip, we can also find a control line which can maintain the test is controllable. So this test is simple and convenient, and also is fast. That means we only need for 10 minutes or 50 minutes to finish this test, and it is economic. But the limitation is it is not a quantitative test. It is a qualitative test. So we can just tell the clinicians it is positive or negative or weak positive, but you cannot tell the clinicians what titration of this antibody is. So it is just quantitative is the limitation. And the second limitation is it is a manual determination. So there was some discrepancy between different peoples to interpret the result. So we will look for other methods which have higher sensitivity. The second method is enzyme-linked immunosorbent assay. We usually call it ELISA. ELISA is our very familiar method in immunoassay. And in this assay, we will use a labeled antigen in the 96 well place, and we'll add the samples in. That's the IgM and IgG antibody samples to combine with antigens on the plate. And after that, we will add anti-IgM or anti-IgG antibody to it. So after that, we will create antibody, antigen, and antibody, and combined with the enzyme. So that is a complex which will show the positive or negative result of the antibodies in the original samples. And this method was shown to have high sensitivity, but it is slow and it is hard to operate because when we use ELISA method to detect antibody, we will use 96 well plates and we will use other instrument to be complementary. And this method is have more interference factors. So the people always smart, so they will search for more susceptible and more convenient method compared to the GICA or ELISA. So we found the chemiluminescence immunoassay, that is CLIA. And CLI, so what is CLI? CLI, we can consider it as a combination of the immunoassay and chemiluminescence assay. So chemiluminescence assay has high sensitivity and immunoassay has high specificity. So we can find it is a very good method which have high sensitivity and specificity. So actually in this method, the major principle is also the antigen and antibody combination, but we use a special enzyme which is called HRP and a special chemiluminescent luminescent substrate. And if the chemiluminescent substrate combined with the HRP, it will create the light, and the light will be detected by the instrument. So it will be very sensitively detected. And this method, we found it has a broader linear range and also have the stable results. This method can also be automatically operated on the machine, and it has it is very fast. In almost today, we can handle with more than 100 samples per hour in the CLIA machine. And sometimes we will also combine the different antibody results to get higher sensitivity and specificity. And this picture comes from the data from the company, and they gathered the 224 serum of COVID-19 patients and 380 serum of negative patients for COVID-19. And they found the combination of IgM and IgG can improve sensitivity. If we just look at the IgM, the sensitivity is 89%. And if we just look at the IgG, the sensitivity is 89%. And if we combine the IgM plus IgG antibody, the sensitivity can reach 94%. So this is also a strategy that we can combine these two indexes to diagnose the COVID-19. And sometimes we will ask for the manufacturer whether they have the cross reactions to other viruses or to other interfering factors. And actually in China, the manufacturers also have done some tests on the cross reaction effects. And they found the machine did not have the cross reaction with the many respiratory infection viruses, such as other human coronaviruses, HKU1, OC43, and L63, and 229E. And they don't have the cross reaction with other viruses, including influenza A, influenza B, rhinovirus, human cytomegalovirus, and other adenovirus enteroviruses. So these viruses are also common in the human infections, especially for the respiratory tract infections, but they don't have the cross reactions with SARS-CoV-2. And if we use the CLIA method, we can also find other interference factors will be decreased. such as rheumatoid factors and anti-nuclear antibodies, will be decreased to a very low level. And finally, sometimes in some institutions, some researchers will use the fluorescence immunochromatographic assay, which is called FICA, to detect IgM and IgG antibodies. Actually, this is a method which combines the advantage of the GICA and the fluorescence immunodetection method. So it has high sensitivity and stable result, and it also need a very small specimen volume. But the limitation is it should need additional equipment and low specificity compared to the CLIA. So actually, the FICA were not approved by the NMPA recently. But from my point of view, it is also a very good method which can be used in institutions and even in some hospitals. And the third part is how to interpret the antibody results. Actually, this is a hard question because antibody is the material which were created by the human bodies. It is not directly linked to the viruses. Actually, it is not a part of the virus. It is a part of the human. So how do we use an index of the human being to indicate the infection? This is a difficult question, but I will discuss this into different parts, and I will divide it into different situations to let you know how we look at the result. And the first principle I want to raise is the antibody test should be combined with nucleic acid detection. So we cannot read the antibody test solely or just to use this index to diagnose the COVID-19. We must combine the antibody results and the antigen, especially the nucleic acid result, to diagnose this disease. So the first column is RNA detection result. The second column is IgM, and third is IgG. So let we look at this table separately. If the RNA is positive, but IgM and IgG are all negative, so this probably is window phase. So what does the window phase mean? Window phase means you have contacted the virus, but you have not the clinical manifestations. So this is the window phase. So the window phase, we can detect the RNA, the nucleic acid in the specimens. Is maybe the nasopharyngeal, maybe your sputum, but the antibody cannot be detected in your blood. So the antibody negative, or the concentration is too low in this stage. And second, if the RNA is positive, IgM also positive, but IgG is negative. So how we can interpret this result? Because the RNA is positive, so the patient should be COVID-19 patient. But what stage of this patient? It is probably early stage of infection, and this indicates recent infection. And in this stage, IgM is detectable, but IgG is IgG's concentration is too low to be detected. So this is the result. And the third result is RNA positive, IgM positive, and IgG positive. So what is the stage? The stage is the infection progress stage. And we can find the virus active proliferation, but a certain immunity arise. So we can detect the protective antibody, that is IgG antibody, in our blood. And we can also find the virus, nucleic acid, and also the IgM antibody, which indicate the active phase. So actually, it is a middle stage of the infection. And finally, RNA positive, IgM negative, IgG positive. This always probably middle stage and late stage of infection because IgM diminished. So it is not an acute phase, but IgG arise. We can find this is a protective antibody, so then it should be a late stage of the infection. After this stage, IgG will remain high titration. And secondly, we can see the result of the situations which showed the RNA negative result. RNA negative result, we must see this situation very carefully because this is a difficult situation. RNA negative didn't mean these people is not COVID-19. Sometimes because of the sampling problem and because of the handling procedure of the RT-PCR, we also result to the false negative of the RNA detection. So if we detect the if we can detect the RNA, but we can also turn our attention to the antibody detection. So the first RNA negative, but IgM negative, IgG positive. So this is probably a previous infection, and the person is recovered from the disease, and the virus was eliminated. Antibody monitoring is required to prevent recurrence. So actually, this person is safe. It is not contagious to other person. And the second situation is RNA negative, IgM positive, and IgG positive. So this is probably a progress stage or recovery stage, and require dynamic detection of antibodies. So this is a situation which is hard to analyze, and we can analyze this situation into three parts. The first situation is dynamic monitoring of the antibody. If IgG titration increase, indicates progress stage of infection. So this is actually a dynamic diagnosis of this patient. So we must have two samples. The first sample is the acute phase sample, and the second sample is from the convalescence sample. And only the IgG titration of the convalescence is four-fold higher than the acute phase. The diagnosis can be confirmed. And the second result is virus eliminated and IgM titration decreased but can be detected. If following IgM turn negative, the infection can be determined and in recovery range. So we can also need dynamic monitoring of these antibodies. And the three parties, RNA false negative, require more tests. And secondly, if RNA is negative but IgM positive, IgG negative, this is probably early stage or progress stage, require dynamic detection of antibodies. The first is the dynamic monitoring of the antibody. If IgG turn positive, indicate progress stage of infection. If remain negative, consider IgM false positive. And the second possibility is RNA false positive, and it require more tests. And finally, if we found the RNA, IgM, and IgG all negative, so we can report negative for this time point. But we cannot exclude this person of the COVID-19 because everything is changed. Everything is changing every time. So if the patient is susceptible, continue RNA and antibody detection in these cases. So from the analysis of these two slides, you will find the interpretation of antibody actually is not a very easy thing. It must be combined with the result of the nucleic acid detection. And finally, we'll talk about the false positive and false negative of the antibody detection. So what is a false positive? False positive means you report the positive, but it actually a negative person. And false negative is you report negative, but it actually a positive person. So why this? Why does this happen? Actually, from the point of the diagnosis, of the diagnosis methods, we cannot find a diagnosis cutoff value which can very accurately, that it means 100%, differentiate healthy population and COVID-19 population. And from the antibody measurements, we can find the healthy population and the COVID-19 population always have overlap between the values of the antibody measurements. So sometimes we can find the negative area, the positive area, and the gray area, but we also found in some area in the negative, they also have the positive populations. And in the area of the positive positive report, we also found some negative, that is healthy population person. So actually, there, because of the existence of the overlap, we will definitely encounter the phenomenon of the false positive and false negative. So from the point of view, we can say the false diagnosis cannot be eliminated by the test. So people will ask, what makes false positive? And actually, the false positive come from several factors, mainly from internal factors and external factors. Internal factors included rheumatoid factor. Rheumatoid factor is a kind of autoantibodies, always IgM, which can non-specifically bind to denatured IgG. And we can find many patients in hospitals, especially patients with rheumatoid arthritis, SLE, and some infectious diseases. And even 1 to 5% healthy person carry RF in their blood. So this is not a real situation. This is very common. So the rheumatoid factor will interfere with the result of the antibodies, especially the IgM antibody detection. And we will also find some other factors which will lead to false positive, that is heterophilic antibodies, and also complement in blood and other autoantibodies, and cross reactions with other coronavirus antibodies, because most of the products use the N protein or S protein as the target protein. So we can find the SARS-CoV and the MERS-CoV and SARS-CoV-2 sometimes will have very similar N or S proteins. So if we use similar proteins, it will cause cross reactions. And some are external factors. External factors including insufficient clotting or blood sample, which can result to residual fibrinogen. And the residual fibrinogen sometimes will cause false positive. And the second is sample will start to lung. So in this situation, the IgG will assemble and makes the baseline too high. And the third is the hemolysis. Hemolysis is very common in hospital practice. And if the blood is hemolyzed, the hemin will released, and the hemin has the activity of the hyperoxide, which can interfere with the HRP in CLIA method. And sometimes the contamination by bacteria in the sample will also lead to the false positive result. So how should we interpret false positive result? It is not how to interpret, it is actually how to identify false positive results. So we must have a concept in our mind, that is IgM and IgG false positive is very common in clinical practice and cannot, and this is very important, cannot be completely eliminated, even though some measures such as dilute sample or use absorb rheumatoid factors can be done to decrease its effect, but it cannot eliminate it. The second is false positive may lead to unnecessary separation and panic of the patients. So the false positive result is also very bad to the control of the disease because it will cause the panic in the populations. And antibody results should be interpreted together with RNA detection. False positive IgM and IgG results should be carefully recognized because they're very important. So let's look at a case which is very interesting. So this is a case in our hospital, and which occurred 2 months ago. And this is a female patient, 52 years old, and she has fever for 5 days, and the max temperature is 40 degrees centigrade with muscle and joint ache. And she has a previous diagnosis in our hospitals as community-acquired pneumonia, and the treatment is ceftazidime plus imipenem. Also, she has a past medical history of cervical carcinoma and experienced radiotherapy and chemotherapy. He denied the epidemiological history, but the vital sign is temperature 38.6 degrees, HR 110, and BP 160, SpO2 98%. And laboratory examination shows the blood count normal, and the liver and renal function normal, or and decrease in the course of the disease. And the anti-BNP 368, hsCRP is high. Blood gas should some abnormal blood gas. So how about the clinical manifestation? Actually, the patient is a patient with fever, and he go to our fever clinic. So how should we differentiate this manifestation to the typical COVID-19? The typical COVID-19 has the main manifestation including fever, fatigue, and a dry cough. And sometimes in a few cases, they have nasal congestion, running nose, and severe patients develop dyspnea or hypoxemia after 1 week and may progress rapidly to acute respiratory distress syndrome. And it is also noteworthy that for severe and critically ill patients may only present with moderate to low fever or even no fever at all. So actually, it has the patient has a manifestation of the typical COVID-19, but the clinical manifestation is not enough. We must look at the chest imaging of this patient. So we can have a look. We can have a look at of this chest CT. So in the chest CT, we can find multiple splinters in upper middle lobe of right lung and upper lobe of left lung. So actually, this is just splinters. So it's not very specific for the COVID-19 diagnosis. And after the diagnosis and after the consultation to the radiology clinicians, they didn't think it is a typical COVID-19 CTs. So what is the typical chest image of COVID-19? In the early stage, imaging shows multiple small punchy shadows and interstitial changes more apparent in the peripheral zone of lungs. As the disease progresses, imaging shows multiple ground glass opacities and infiltration in both lungs. And in severe cases, pulmonary consolidation may occur. However, pleural effusion is real. And in this case, we have done 3 times of the RNA detection, and 2 samples from nasopharyngeal swab and 1 sample from rectal swab, and they all showed negative result. And we did the COVID-19 IgM detection. It showed weak positive for 2 times. We use GICA method in this patient, and flu A, flu AB, and R3 is negative. So in this point, how do you think this is a suspected patient, or can we exclude this patient of the COVID-19? So Actually, from the point of the clinicians and the radiologists, they all did not consider it as COVID-19. But how can we interpret the COVID-19 IgM weak positive result for 2 times? Actually, after that, we did the rheumatoid factor absorbance, and it also showed the weak positive. And after that, we also did the multiplex PCR detection of respiratory pathogens. And after we did this, we found a very strange result that one respiratory pathogen, nucleic acid, is positive. In this patient, we have screened the 18 types of respiratory tract viruses, and the coronavirus 229E is positive in this patient. So actually, this is a coronavirus which is very common in the upper respiratory tract infections, but it is not SARS-CoV-2. So actually, we can sometimes consider this coronavirus C229E cause the false positive of the SARS-CoV-2. So sometimes how should we discriminate this phenomenon? Actually, I draw a picture on the dynamic monitoring of antibody titration. And sometimes the most difficult situation that we encounter is virus RNA negative, but antibody detection positive. So how can we handle this situation? So the virus RNA negative, actually we can say this is maybe true negative, but maybe false negative. So we must do the antibody detection. So if you found this patient is virus negative, we can do antibody detection. If the antibody detection is IgM positive, but IgG negative, we may consider it as acute phase suspected. Then, but then we must do test antibody again after 7 days. If after 7 days, we also did the IgM positive, but IgG remain negative, we must consider this IgM positive is a false positive. But if we found the IgM positive, IgG positive, or IgM negative, IgG positive, that means IgG turned positive after 7 days of this stage. So we can consider it an acute infection confirmed. And secondly, we can find this strain. If we found the virus RNA negative, but IgM positive, IgG positive, we can actually think it acute phase suspected and test antibody again after 7 days, especially IgG titration. So if we found the IgG negative, IgM negative, IgG positive, or IgM also positive and IgG positive, we can see the IgG titration. If IgG titration increased 4-fold compared to the 7 days ago, we can also consider it as acute infection. And this slide, if the IgM negative, IgG positive, we can find it is IgG false positive or previous infection and test antibody again, especially IgG titration. IgG titration increase 4-fold indicate the recent infection. And finally, this one, IgG negative, IgM negative. But we also consider or suspect this person is a COVID-19 patient. We must report antibody negative, but we must also test antibody again after 7 days. If after 7 days, if we report negative, the antibody is negative, but test and report as left procedure if IgM or IgG turned positive. So this is a flow chart of the situation that we must handle if we encounter this very difficult situation. And the antibodies will also will face false negative. False negative, the reason include window phase, the antibody concentration is too low to detect it, and the inappropriate sample or reagent storage and low sensitivity of the kit. So finally, I will have a summary because from the point of the diagnosis of the infectious disease, the antibody is a method, but we cannot use it as a sole method to diagnose this disease. So 2019 nCoV antibody should be used as a complementary tool for nucleic acid negative suspected patients. It is useful in the diagnosis of the patients and screen for the symptomatic infections. And for suspected patients, antibody detection should be carried out for at least 2 times, one for acute phase and the other for convalescence phase. Dynamic analysis on the antibody digestion is helpful for COVID-19 diagnosis. Antibody tests alone should not be used as a confirmatory or exclude test for COVID-19. So this is a summary of our my view to the antibody detection of the COVID-19. And this is my last slide. This slide is very interesting. The left side can recognize which year of this picture is. Actually, this picture comes from the year of 2000 and 2003, and that is the year that we faced and fought against SARS virus in Beijing. And this picture was taken in our hospital. And after 17 years, we have the chance to combat COVID-19, and we also have the confidence to control it. So thank you very much.
Okay. Excellent presentation. Thank you, Professor Yang. I believe you will do better in the next session for the question to answer the question. So also, I don't want to give a comment and a summary, so I want to leave a little more time for the next section. Say now we can to change into the question and answer session. Okay, so we can to get some question to me. Yeah. Okay, the first question I have got, from the research, we talk about the secondary infection. How long we can see the secondary infection in patients after first infection, and how we can confident that is a secondary infection, a lot of false negative from the first infection, and then positive later, that we can detect as the secondary infection. Maybe it's not a secondary infection, just the first the text is the patient cover is the virus nucleic test is positive, it's negative. Maybe the patient is covered, but maybe it's not. It's just the virus is less can you detected. So yeah, who can do to Professor? Who can do answer this question?
May I answer?
Yeah, thank you.
But first of all, I'd like to thank you, Professor, for this very interesting webinar. And I like to say that I'm delighted to be here with you to discuss a very interesting topic. The question is very intriguing, and it's clear that nobody should ask should answer totally to this question, because it's an open question. But what we can say is that we need to have more evidence about the so-called secondary infection. That means that we really need to know how long after the relief, the finish of the symptoms, and after one or two molecular tests negative, we can say that the infection is totally defeated. And only after answering to this question, we can say if it's true secondary infection or if simply the virus was still working in the body and we did not detect its presence using traditional tests. So we need more time to answer the question, and I invite all scientists and physicians to have at least 2 molecular tests, to wait more than 14 days after the onset of the disease to be sure that the infection is completely defeated and the virus is no more present in the body.
Professor Wang, can I add something?
Yeah, can you?
Yes, I actually, as for this question, I think the recurrent infection will appear, and also this is also a common situation in the clinical practice. But how we can recognize this situation from the initial infection is we can detect the antibodies in the patients. If the patient is initial or original, the first time infection, we can just detect the IgM antibody in the time of onset. But if this is a recurrent, if this is a recurrent patient, it should this patient should have experienced infection maybe several days or maybe 10 days ago. So it should have IgG antibody in this patient. So if this is recurrent, we can detect the IgG plus IgM antibody in the patients at the time of the onset. So for this patient, I think the antibody detection will be helpful. But actually, we can also differentiate the situation that maybe in just a very special period, we missed the nucleic acid detection, and we didn't find the nucleic acid in the body. This is also common, and actually, I have ever read a manuscript which was published by our Wuhan colleagues, and they have found some patients have the recurrence after they detected the nucleic acid for negative result, and after 10 days, the patients turned positive again for the nucleic acid. So we can say in some patients, the nucleic acid will remain in the body, but you can't detect them because the concentration is too low to be detected by our routine RT-PCR. But the virus is in the body actually. So after this virus proliferation in the body for several days, it can be go up and grow up to a detectable level. So actually, I think firstly, I recommend to detect the IgG plus IgM antibody firstly, and then you can also change the RT-PCR method to check whether the nucleic acid is still remain in the body. Thank you.
Okay.
May I add just a sentence? I totally agree with my colleagues, and I totally agree that we have to discuss the sensitivity of RT-PCR sometimes, and so the additional information by IgG, particularly in this patient, is very important. Thank you so much.
Yeah. Ignorant as a perfect to answer. So I change it to second question. Could simple positive COVID-19, interference a larger sample or next sample in centrifuge without the cover in the rotor? If any, how many percentage, of the risk? Because I check some level, don't have the rotor with the cover. Just, who can you answer this question?
May I answer this question?
Okay, yeah.
Okay, I consider it as a carrier contamination of this question, because we will handle with several specimens, maybe 10 or 20 or 30 specimens. So when we handle with these specimens, there is a situation that the errors will increase and maybe have the cross contamination, or we'll also call it carrier contamination. But in my experiences in many hospitals of the laboratories, we actually have the cap on the blood tube, and we have the capped tube in the centrifugation. So actually the aerosol can be controlled. So in our hospital we didn't find many cross contamination in the test. But actually we also suggest that we must prevent the aerosol contamination between samples. And I have the recommendation that is after the centrifugation of the blood tubes, we must make the cap of the centrifuge and also make the tubes make it still for at least 5 to 10 minutes. So this behavior can effectively drop down the aerosol and decrease the effect of the aerosol contamination. So that's my recommendation. Thank you.
Fundament? I forget to open the, yeah. So to repeat again, Professor Benny, do you have any supplement?
No, I think that the answer was totally fine, and I agree with the professor explanation. So thank you.
Okay, thank you. So the third question, what exactly happened when a person recovers from suffering COVID-19, lower coronavirus, with a recover from suffering COVID-19?
Actually, I have some patients in our Peking Union Medical College Hospital, maybe two months ago, and I have some experiences on the patients which is suffering from the COVID-19. Actually, especially in Beijing, we faced many mild, that is non-severe patients. In these patients, many indications of the especially for the blood chemistry or blood cell count may be normal. But as for the severe patients, they will have very severe pulmonary diseases in these patients. And we can, from the point of the clinical laboratory, we can find the decrease of the blood oxygen and also the increase of the myocardial enzymes and maybe cardiac troponin. And we can also find the liver function and renal function damage. As for the blood count, we can the most important change is the decrease of the lymphocyte. So why is the lymphocyte count decrease in the course of the disease? Actually, we can find that this is actually a virus infection. So lymphocyte is very important to eliminate the virus out of the body. So most of the lymphocyte come out of the blood and go to the tissue, go to the lungs or other organs. So the lymphocyte in blood will decrease. So this is very easily to be understood. And but we can find the lymphocyte count in blood is a very important index for the diagnosis and also the progress of the disease. If the lymphocyte count in blood is very low, also always indicates the progress is not very good of this patient. So the lymphocyte of CBC is also important, and we can also find the platelet drop, and also the longer time of coagulation. That means sometimes we can find the abnormal indexes on the coagulation function in the body. And if you encounter some patients who recover from COVID-19, we can find most of the patients, if he or she recovered, maybe you can just look at him as a very healthy person. But more or less, the pulmonary function will be affected, and maybe the liver function and the renal function will be abnormal for a certain time, maybe several months. So this is a part that we can see from the patients. Actually, most of the change in the index of the blood and in the other index of the patients depends on the severity of the disease. If the patient is very severe, we can see many index change. But if the patient is just a mild or not so severe patient, we didn't see many index change.
Okay. Yeah. Thanks. And maybe some sero patient. Maybe it's mild. Just Professor Yang said maybe mild patient is nothing where you recurred. But for the sero patients, maybe used for corticosteroids, yeah. Corticosteroids, maybe some GICA. GICA you used for the patient, maybe where to cause the several communication, including osteoporosis or osteocrosis. Just the bone, maybe the bone some impact the function. Yeah.
Okay.
Yeah. Now, for first, the question is, the combination of the PCR. What is the benefit to combine, RT-PCR in the serological test for diagnostic COVID-19? What is the benefit together? Combine together the combine RT-PCR in the antibody test. Okay. What is the benefit? What is good for? Yeah. What is the benefit?
Yeah.
Yeah.
So first of all, I like to remind you that as all other laboratory tests, even RT-PCR for the virus SARS-CoV-2 is an imperfect assay. That means that there are some vulnerabilities, as I presented you. So sometimes a negative results should be carefully considered on the basis of the clinical and other data, and even some positive results
should be carefully taken into account on the basis of the clinical and laboratory data. So we know that RT-PCR is a gold standard, but this does not mean that it is a 100% accurate test. Therefore, as my colleagues previously said, the additional value of serological test sometimes is, but first of all, is to study the immune response of the patient, of the individual. That is very important to better understand the pathophysiology of this disease. Second, there is an additional value in demonstrating the presence of IgMs at the beginning and IgG later on of the disease. And as my colleague said before, to confirm sometimes a secondary infection. The other value of serological test, of course, is epidemiological surveillance to understand what is the prevalence of the disease in the population, and finally to know if there are the antibody in the plasma serum of some patient, which should be eventually taken into account to donate the plasma for treating some particular patient with active disease. So I believe that there are many, many opportunities to use serological tests.
Yeah, Professor Yang, do you have some word?
Actually, from my point of view, I think the nucleic acid detection and the antibody detection is both very important, because both of these two methods have their advantages and disadvantages. The nucleic acid detection sometimes is much sensitive than the antibody detection, but it also will be affected by many other factors, such as sampling problems, such as the stage of the infection, and also the methods which we chosen to do the RT-PCR. So in some phase of the infection, we can add the antibody detection method to be a very good complementary method of the nucleic acid detection. So that's my point.
Okay, great. And next question is, what is the minimum days to detect, COVID-19 antibody, IgM, IgG antibody after infected by the virus? What is the minimum days?
Okay, according to the literature and our experience, it takes 10 to 12 days after the onset of the symptoms, fever in the case, 10 to 12 days, we have to wait to detect IgM, and later on, after a few days, the IgG in the plasma and sera of patient with the COVID disease. So 10 days is the minimum to achieve a good percentage of positive patient with IgM and IgG. This is the kinetics we have described in some papers.
Yeah. Have some, Professor have some supplement?
No, I agree.
Yeah, okay. Thank you. Next question is, what are the characteristics of blood routine in the biochemical test results in the patient with the COVID-19?
Okay, so this is very interesting question. Once again, we saw, and I demonstrated in my presentation, but my colleagues made the same consideration some minutes ago, that there are many tests which should be used to better understand the severity, the degree of the infection. So we are using particularly hematological tests, lymphocytes, neutrophils, platelets, to better understand the degree, the severity. We are using procalcitonin to understand if there is a superinfection by bacterial superinfection. And the same was demonstrated recently by our group using presepsin, that is a quite new biomarker of infection. And D-dimer, among all other coagulation tests, is very important. It is well demonstrated the value of D-dimer increase in differentiating more severe diseased patients from less severe, mild, severe, and mild disease of COVID. And for detect the liver disease of comorbidities, transaminase are very useful. Lactate dehydrogenase is useful to better understand the lung, how much the lung are compromised. And for kidney disease, of course, the creatinine is very useful. And for the inflammatory inflammation, biomarkers are PCR, C-reactive protein, the erythrocyte sedimentation rate, and interleukin 6, that is another interesting biomarkers that should be used even for monitoring the answer, the response to some well-directed therapy. So we have a lot of tests to be performed. Sometimes they should be performed every day during the active disease phase, and for other, one per week or one on other 2 weeks. But this is a very interesting point because the laboratory tests are very, very useful for patient monitoring.
Okay. Yeah. Next question is for the evaluation of the test performed IgM, IgG on CLIA, chemiluminescent immunoassay method. Have you got the results of the cross-reaction? Cross-reaction with other virus association with other respiratory syndrome?
Let me answer this question.
Okay.
Actually, the problem is the cross reaction in the methods. The cross reaction, why it is happen? Why does it happen? Because in the method we have the antigen which can react with different antibodies. Different antibodies, but the different antibodies come out from the different pathogens. So especially for the point of the SARS-CoV-2 virus, actually we found the king protein that we also use as the immunoassay is N protein and S protein. N protein is very specific, and S protein, the spike protein, is also specific. But actually, in the coronavirus family, they all have the N protein and S protein. So actually, sometimes we cannot get the very good, maybe the best. We cannot get the best proteins, N or S proteins to do the test. So if the specificity of the N or S protein is not so good, we will encounter the cross reaction. But in our hospital, maybe in other hospitals, using the chemiluminescence immunoassay, we found the cross reaction is very real because most of the manufacturers found the good protein. That's that way that they use in the methods. But in the colloid gold chromatographic immunoassay, sometimes we encountered the cross reaction. Just I have showed in the slides 20 minutes ago, we have encountered the cases which showed the false positive of the colloid gold immunoassay. And in that case, the patient is actually infected by the coronavirus 229E. So the coronavirus 229E is also a family of the coronavirus. So maybe the kit is not so specific, so it has a cross-reaction with another coronavirus. So sometimes we will encounter this problem, but I actually, from my point, I think the cross-reaction is the possibility is low. Thank you.
Okay. Because the time is nearly come to. So for the last question, have a lot of many questions. So just the last question. Okay. I want to inquire about the potential risk. A potential risk of the acquiring infection from manipulation of the sample, such as blood, urine, or stools. Okay. Okay. I think Professor Yang, you can continue. Okay. You maybe process where to have a supply. Okay.
Okay. I just talk about my opinion, and Professor Mario, please add it. And actually, from the potential risk of the infection, if we, especially the laboratory staffs, handle with the different specimens such as the stool, such as the blood and the urine, what is the possibility of the staffs getting infected by the SARS-CoV-2? I think the possibility is very low, because we can analyze this point from the transmission route of the virus. So the living virus was detected in blood, in urine, in stools, and in respiratory tract. And actually, most of the specimens have the living virus, but the key transmission route is by respiratory tract. So the most important for the laboratory staff, I think, make safe for your mouth, for your nose, that is for your respiratory tract. And the second is make your body clean. That is, you don't have to contact the face, contact the surface which is contaminated by the virus. So the hand hygiene will be also very important. And the third route is infection by the aerosol. The aerosol infection is sometimes have the risk especially in the laboratories. But if we do the protection on our face, and we also do the protection on our hand, I think the aerosol contamination can be prevented by our method. So actually, before the conference, I found Professor Plabani also wears a mask. So I think it is a very good method to make you protected from the virus. Thank you.
Yeah, Professor Panamani, do you have some word to talk something?
No, I have my mask.
Yeah, no. It's very important.
No. I am alone in my study, so in my room there is no other people. But we are using the mask, and we know that that is an effective tool to defend ourselves and to defend the laboratory staff. I like to add that is another matrix biological component very important that is we have to carefully consider, that is the saliva, because saliva is potentially dangerous. So I totally agree with my colleagues. We have to adopt not only the mask, but hand hygiene, and we have to use to work under the cabin for some particular management of biological samples. But I'm sure that our staff should follow carefully the guidelines. We can save ourselves, and sometimes is easier to have a contact with asymptomatic people to achieve the virus than working in the lab.
Yeah, thank you very much. So the time is up. You know, if a longer time, I had to pay more money. So, so thank you for the professor to excellent presentation. Also, thanks all the people to come together to give a lot of questions to discuss something. Okay, thank you. Bye. And I say time is this activity is finished. Bye.
Thank you so much.
Thank you.
Thank you, Professor Mario.
Great day in China.
See you next time. Yeah.
Thank you for the Mindray.